So you mentioned at the outset of the presentation the New York Times Magazine piece and also the MTA study on ADHD. And, there was a piece of information in that magazine piece. The author said, quote unquote, that the relative benefits of stimulant medication were shown to fade after 36 months, according to the MTA. But, Dr. Russell Barkley and others have come out and said this interpretation of the MTA is incorrect. So I wonder if you could just help us understand the kind of the bottom line, what we know about medication efficacy over time, and whether we can feel confident that it will continue to have a positive impact on ADHD symptoms after 36 months.
Yeah, well, I think, I guess I agree with Dr. Barkley. The issue with the MTA study is that it was a study for 14 months, but then after that, people could do what they wanted to. In other words, the first 14 months, they received very specific treatments and suggestions about how to treat their ADHD. But after 14 months, people did what they wanted. And so lots of things kind of can influence that. Certainly, if you're more severe, you're going to probably want certain treatments. If you're better, you're going to not need certain treatments. And it just makes it really hard to evaluate the impact of the initial treatments. But clearly, all the treatments worked. Everyone got a little bit better at the end of 14 weeks. But the data that we have most confidence in is from those first 14 weeks. The follow-up studies don't really tell us that the impact of the treatments. So I'm sorry, my screen keeps moving. Sorry.
Oh, no problem. Right. Yes. Basically that after 14 months, the folks in the control group were free to try medication, and the folks in the medication group were free to stop taking medication. So you really can't say much about
Yes,
that efficacy just based on MTA.
And the article really ignores the experience of people with ADHD and people who treat ADHD, who knows that treating it really can be life-changing. I also thought the New York Times article ignored the many studies that show the benefits of stimulant treatment, not just on the child, but how they interact with others, the impact in the classroom, the impact on families. And now we have more data in terms of long-term effect in terms of reducing risk of significant negative outcomes, psychiatric outcomes, and medical outcomes.
Right. Yes. I mean, the data just on how use of stimulant medication lowers the risk of car accidents. It was, for the parent of a teenager, a critical piece of information for me. But there are plenty of others regarding preventative benefits of ADHD medication that I think are important for people to know about, that, as you said, were not mentioned in that New York Times piece. And that really comes, parents' concerns are prevalent in the questions that we're receiving today. And you talked a bit about the side effects that are kind of most common, and certainly the sleep side effects with ADHD medication. Another one that I'm hearing a lot today is regarding appetite suppression. And I wonder what we know about the impact of stimulant use on appetite and then on growth. And at what point should parents be concerned that what they're seeing is a sign that their child should try a different treatment strategy?
Yeah, well, it's well known that one of the most common side effects is decreased appetite. And especially when you start an ADHD medication, that tends to occur. And I think the important thing is to pay attention to that. We worry about weight loss, not so much decreased appetite, because usually they catch up. But there are different strategies, and Dr. Waxmansky has done some really great work showing that different strategies, such as giving supplements, monitoring weight, and if necessary, medication holidays on weekends can help mitigate that effect. But one of the physical aspects of stimulant treatment that are important is monitoring weight and monitoring cardiovascular effects. And that's why it's important, to work closely with your child's primary care physician to monitor those. And again, if they start losing weight, then there are options, much like sleep, in terms of trying a different medication or changing the dose. Those sorts of strategies can be helpful, but you don't just give up on ADHD treatment because of that.
Mm-hmm. Okay. And onto the sleep side effect. A number of people saying that they've read recent research suggesting that a low dose of a stimulant may actually be shown to improve sleep, especially among children. Just wondering if you could speak to that, and that we shouldn't assume necessarily that the stimulant is having a negative effect.
Yeah. So this is an area that there's been some recent research on it, but there's more that's needed. But I think my read of that research is that for most of the time, stimulants decrease. They have an effect of making it take longer to fall asleep. But there are some children who, if they take medication later in the afternoon, are more organized and are able to get to sleep. Now, the question is, what percentage of children, and can we identify them somehow in advance? But there are definitely cases like that. Now, whether it's 20% or 30%, I'm not sure. But that's certainly something worth trying. But again, we need more research to identify the predictors. But for most children, the later you take a stimulant in the day or the higher the dose, the more likely you are to have problems like insomnia. Now, the other aspect of it, though, is that you're likely to sleep more soundly. So it changes your sleep pattern. But one of the common problems children with ADHD have is waking up in the morning then. So again, paying attention to that and developing a strategy is really important.
Okay. And there are some clinicians, in my understanding, that are using the combination therapy, and specifically sort of long-acting stimulant, early in the day, followed by a non-stimulant later in the day that could actually promote sleep.
Yes. We don't have that many studies of combination treatment, but we have some, especially combining a stimulant with an alpha-2 agonist like clonidine and guanfacine. And studies that have been done actually show improved tolerability, and you can use a lower dose of a stimulant when you combine it with an alpha-2 agonist. And the alpha-2 agonists have been shown to make it easier to fall asleep. So that's a very common combination that has been used.
Great. Okay. So something to, and again, I should preface and say these are all talking points for, we hope the parents and adults with ADHD listening will bring to their doctors. And a number of questions from parents who said that, one in particular, that her son has tried a number of different stimulants, also CBT and executive function training, and is still really struggling. Wondering if this is a sign that the diagnosis is incomplete, or perhaps that they just maybe need to try, a different kind of stimulant, a methylphenidate versus amphetamine, or vice versa. What about these folks who feel like they've tried quite a few solutions, and the combinations aren't paying off?
Yeah. So Dr. Sam Cortese has recently written on these types of cases that are refractory to several medications. And one of the questions the provider should answer is, well, first of all, have I done adequate titrations? I mean, have I evaluated several different doses to see if the dose is the issue? And then have they tried different classes of medication? So if they tried the stimulants, have they tried the non-stimulants? You should always reconsider the diagnosis, although medication response is not a way that we evaluate if you have ADHD or not. But in cases like that, it often helps to get like a second opinion or a fresh look as well from someone else. So those are all the things that I would suggest too.
Yeah, very tricky. Okay. And is there any rule of thumb for parents for their expectations of how many medications and dosage variations they should expect to try before they, go a different path? How long does this take?
Okay. Well, most of the time it doesn't take long. At least in children, the data suggests that if you individually titrate on a methylphenidate, about 75% will respond initially. And if they don't respond and you try an amphetamine, you'll get to 90%. Those might be a little bit high, but I think if you add in trying a stimulant and a non-stimulant, and they're well titrated. The other aspect that I think is often missing is what is the psychosocial treatment? And are we expecting too much from medication? You always want to look at the complete picture and, what are the services they're getting at school and what's at home.
Right. And that's a segue to some questions we've been getting about the impact of medication versus CBT and or parent behavior training on specifically executive function and emotional dysregulation. Are those two facets of ADHD, do they benefit more from medication? Do we know, or do they benefit more from the psychosocial interventions?
Yeah, that's actually a hard question to answer. There are some meta-analysis that have looked at medication effects on emotion regulation and executive function, and they are helpful. It's not a large effect; it's a medium to small effect size. So you would expect medication to help a little bit, but again, medication doesn't teach skills. So the question is how to teach these skills. But the other aspect is development. And this is something that executive functioning that continues to develop as children age. We used to think that, teenagers had good executive functioning. And now we realize that the parts of the brain that really involve advanced executive functioning are still developing, age 18, 19, and 20. So there's just a lot of variability, but you have to take age into account. The interventions like teaching executive function skills, they're challenging. I think they work better in adolescents. I haven't seen strong evidence of them in young children. So that's not something that I would emphasize.
Gotcha. Yeah, we hear that a lot, that the medication is helpful for getting the child to attend to the psychosocial interventions. As you said, the skills themselves don't teach the skills, but perhaps they create the time and the space to work on that skill building.
Yes. Emotion regulation, though, is something that does tend to respond to behavioral interventions, especially because many times the emotion dysregulation comes about due to noncompliance or due to rapid behavioral escalations or due to lack of structure. And increasing those things and those skills often does affect that in a positive way.
Wonderful. Okay. So a few questions from parents of younger children. There's a parent here of a 5-year-old who has whose doctor is hesitant to diagnose and even more hesitant to talk about treatment with medication. For parents of young children, generally speaking, do you recommend that they start with the parent behavior training prior to medication, or is that an outdated way of thinking?
No, I agree with that, unless the symptoms are so severe. I guess the two things that matter to me is the child's life in danger. I remember hearing of a case where like a 5-year-old with hyperactivity darted out and to the street and, got hit by a pickup truck. I mean, in that case, it's really life and death. And then I think the more challenging cases are someone that is really struggling in school, getting kicked out of school, and that really is having a significant negative effect. And depending on how comfortable the parent is, that's something maybe to consider. I think after an evaluation and a diagnosis, there needs to be a discussion about what are the benefits versus the risks of each of the treatments and what we know about and what works best. And sort of using a shared decision-making approach with the families, coming up with a plan I think that's often what's helpful in putting it in perspective. But what you don't want is the parent kind of abandoning all treatment or doing something that we know nothing about. And there are a lot of non-evidence-based treatments that people are very vulnerable to.
Mm. Yes, indeed. That is a great point. And to that point, someone wrote in to say that their pediatrician said she doesn't recommend medication until the child is quote unquote in crisis. They're looking for a new pediatrician, but sadly it seems that this is not uncommon.
Yeah. So ADHD medication, isn't a crisis medication. And ADHD is not a disorder like that. I mean, that's not the best time to evaluate medication. It's also not the best time to evaluate when there's a marked change in their environment. So it's best to figure out a good time to do it. But again, when there is a crisis, there's always the impetus to do something quickly. But you want to make sure that you're doing something that makes sense.
Mm-hmm. And, many parents are eager to sort of try everything else before medication. We did a editorial survey here at Attitude that showed that on average, parents were waiting 6 to 9 months before sort of even considering medication post-diagnosis. Would you offer any caution to trying, for example, improving daily physical exercise, clean diet with fewer, processed foods, that sort of thing as a first step for parents of newly diagnosed?
Yeah, no, I love that question. I guess the way I think about it is that you want to have a floor in terms of interventions. And this would be actually primary prevention, not when children are diagnosed, but before they're diagnosed. And that is to make sure that the child is getting adequate nutrition and make sure that they have good sleep patterns. And that's something all children should be trying to establish. For ADHD, though, you're already having significant symptoms. And so certainly you want to target, you want to do what you can to improve sleep and appetite, but depending on the severity, you're going to want to initiate treatment, but you might want to start with behavioral interventions first.
Okay. And one concern that I'm seeing among parents is a worry that stimulant medication itself may be addictive. Yeah. Is there any evidence?
Yeah. I mean, no.
Yeah.
And on the contrary, there are these evidence, especially from the Scandinavian studies, where they have these registries where they're able to track healthcare, and they also have kind of universal access to medications. And what they show in general is that treatment of ADHD with medication lowers the risk of later substance abuse. So it's actually the opposite. We know that untreated ADHD is associated with substance abuse, but treating it actually, in most of the studies, actually lowers the risk. That doesn't mean you shouldn't be cautious and you shouldn't do a careful trial, but that's not something to worry about. I wanted to get back to the parent that says, I want to do everything other than medication. And it's certainly important to hear that and then to understand where that's coming from and what the reasons are. And, my job as a clinician is to kind of give them the knowledge from the research in terms of what we know, like explaining about those studies And then again, it's the parent feeling confident and understanding that makes that decision.
Gotcha. No, that's an important point. Okay. So someone wrote in to say that they're having trouble finding a parent behavior training specialist, and that in fact their doctor has really not introduced parent behavior training as an intervention early on for their child. Are there any resources that you're aware of, places that parents can go to get more familiar?
Yeah, well, this has become a very significant problem, especially post-COVID, as more people have been diagnosed with ADHD, and there are fewer providers. And it's fine to say everyone should have multimodal treatment with strong evidence-based behavior therapy, but it's easier to say it than to do it, and to find someone that can provide that, and someone that takes your insurance, for example. So I guess I have two thoughts. One is universities are usually a good resource. And if you contact a local university, and if they have a psychology department or a clinical psychology department, they may have a training clinic that offers those services. And then the other answer is that technology is kind of coming to the rescue. And now there are online behavioral parent training services that are available. And I think also services like CHAD, the NIMH, the CDC all have links to behavioral parent training services that people can seek out and that they may be able to try. So there's more of those all the time, but
Okay.
It is a challenge. The other advantage post-COVID is with telehealth, though, the parent doesn't have to come in and geographically be next to the clinic. There are a number of telehealth providers that do it. And there's more evidence now that group parent training is as effective as individual parent training for many cases.
Oh, interesting. Okay. That's very helpful. I wanted to go back, if I could, to the comment about the stimulant medication not being addictive. It was mentioned in your slide regarding when to consider non-stimulants, that it might be appropriate when there is the presence of substance abuse. And so I wonder if you could just clarify when that would be the case. If an individual has a history of substance abuse, perhaps they shouldn't try a stimulant medication, or am I reading that incorrectly?
Yeah, I think those are the cases that it's just highly individualized. It really depends on the relationship of the provider with the patient. But people with comorbid substance abuse and ADHD are really challenging to treat. There is some evidence. Dr. Willens has done some studies and others showing you can treat them for ADHD, and it's beneficial without exacerbating the substance abuse. But certainly if the patient is worried about stimulant abuse, that might be an easier lift to start with a non-stimulant.
Okay. Gotcha. Okay. And for those who, we have a few people here who say that they and their child's other parents are not on the same page regarding ADHD medication use. Any words of advice for those people who would like their co-parent to consider ADHD?
Yeah,
medication?
so this is a very frequent challenge where one parent wants to try medicine, the other parent doesn't, that the child is caught in the middle. What I like to do in those cases is to bring everybody together and have a meeting to talk about how a trial is done and what the benefits of a trial to determine if they respond, and talk about the harms done by parents not being together for the child. And then hearing, what are the reasons that the parent is against a trial? Is it because of their own personal use, or is it their own ADHD? In which case, it's important to highlight the struggles that they went through because of untreated ADHD. But again, it depends on the relationship of the parent to the provider and their understanding of what a trial is and what's involved. That it doesn't mean your child's going to be on medicine for the rest of their life. but that at this time, that might be a consideration to see if that would help things.
Wonderful. Thank you so much, Dr. Stein. Unfortunately, that has to be our last question because we are just about out of time. But thank you so much for joining us today, contributing your voice and sharing all of this really valuable insight and research.
My pleasure. Thank you.